Welcome back to the Band-Aid Man OC, your source for EMT, EMR, and sports medicine education. Today we're going to be talking about chest and abdominal trauma. It's going to be chapter 27 in the 13th edition of Emergency Care, our Pearson EMT textbook. The broad topics that we're going to be talking about today are going to be chest injuries and abdominal injuries, and this will all relate back to trauma. So let's start with chest. The chest injuries that we're going to talk about today are fairly straightforward. We've got blunt trauma, compression, and puncture. And on this slide, we'll be discussing blunt trauma and compression. Blunt trauma, for the uninitiated, are going to be injuries that occur where an object or some other type of material strikes our patient but does not break the skin. This can cause fractured ribs, fractures, or damage to the sternum, as well as damage to the intercostal areas, those spaces in between the ribs, as well as the rib segments that are cartilaginous structures as opposed to bony structures. Compression occurs when severe blunt trauma causes the chest to rapidly compress, and it doesn't necessarily need to be where the compression is unabated. It can just be a very short period of compression, and that's all that it takes. One of our more common injuries, especially in the live concert setting, will be individuals that are pressed by the crowd up against the crowd control barrier at the very front of the stage and sustain significant damage even though they were pressed up against the barricade for a very short period of time. Finally, we have penetrating injuries. Any object that breaks the skin would be considered a penetrating injury. So that would be bullets, knives, pieces of metal or glass, steel rods, pipes, other objects, really anything that's foreign to the patient's body that's going inside of them, or by the inverse property, anything that is supposed to be inside of a patient that is protruding out. These objects can damage internal organs and also impair respiration. This is a picture of a flail segment or a flail chest injury. And we're going to be talking about what a flail segment or flail chest injury actually is in a couple more slides here, but this is a quick show of what they are. And if you'll take a quick moment to note that those rib sections have two different structures. The more clear or opaque versions are going to be your sections that are made up of cartilage, whereas the more solid white with the black outline would be the bony structure. So do remember that our ribs are made up of different materials at different places in their structure. Now, when we're dealing with a flail segment, especially here, you can see that because of the disassociation of the rib cage from those bony segments, there's going to be a paradoxical movement. Paradoxical movement is anytime that you have one part of the body going one direction and the other part of the body going in the opposite direction. This paradoxical movement is a sign of significant trauma to the chest and should be noted, and we need to definitely prioritize transport, oxygenation, and prepare for the possibility that that patient may need some assistance with their own ventilation, so we may need to break out our bag valve mask device. Now, we've already talked about these two phrases, but I do want to bring them up again. So let's go ahead and take a look at these. A flail chest is anytime that we have a fracture of two or more consecutive ribs in two or more places. These consecutive ribs need to really be separated in a way that the integrity of the rib cage is actually interrupted. So a broken rib is incredibly painful, and our patient may have significant pain from a broken rib, but it's not nearly as dangerous or concerning to the first responder, EMT, paramedic, whatever the case may be, if we have a patient with a broken rib as opposed to the patient that has a flail segment. And a flail segment will be pretty easy for us to determine when we go ahead and start our physical exam. As we've already talked about in my class, doing our physical exam will include pressing on both sides simultaneously of the chest wall and then pressing down in the center on the sternum. We call this the barrel hoop examination. If our patient is able to take that kind of pressure and we don't feel any deformity and we don't see any massive change in their ability to breathe afterwards, that barrel hoop will be considered negative, meaning that the assessment shows no compromise of the chest wall. On the other side, we have our paradoxical motion. That describes what motion we're actually seeing during a flail chest segment that is significant, where one part of the chest will be sucked into the chest cavity and then the rest of the chest will rise and fall in a similar fashion. Also, we may see that the flail segment is so severe that the rib segments that are disassociated will summarily balloon out. And what that means is when the patient is breathing, you'll see paradoxical movement in both directions. You'll see a deep cavity, a deep depression going into that patient's chest wall, and then they will also have that same area balloon out. So it is important to note that we may see that. Our patient assessment will be following the following 5 points. We want to determine that the mechanism of injury was in fact significant enough to cause this injury. We want to assess for difficulty of breathing as well as hypoxia. We want to assess the level of pain at the injury site. We also want to look for signs and symptoms of shock and hypoxia. And then we also want to try to limit chest wall muscle contraction. When we're doing all of these things, we need to, of course, follow our normal patient assessment. Assess for the ABCs, airway, breathing, and circulation. Administer oxygen if it's appropriate. Be sure to look at your patient's effort, depth, and rate of breathing. And if those things aren't looking right, if our patient is breathing at a depth or rate that is not going to allow them to have sufficient respiration, too fast or too slow, too shallow or too deep, we need to go ahead and we need to support their respiratory drive with artificial ventilation, and we'll do that via bag valve mask. We also want to make sure that we follow our local protocols using non-invasive positive pressure ventilations, and that goes back to the bag valve mask. Positive pressure ventilation, meaning that we are in fact increasing the amount of pressure inside of the chest wall by artificially ventilating. This patient is going to require very, very careful monitoring, and we need to make sure that we remember that this is a critical patient. They definitely need to be monitored, and they need to have their vital signs checked every 5 minutes or less if you feel that it's necessary. And as we've already said before, check for that respiratory rate and depth. With open chest injuries, it may be difficult for you to tell what is injured after the determination of the entrance wound, but you should assume that all open wounds to the chest are life-threatening. See, the problem is that when you have an open wound, it will allow air into an area of your patient that air should not normally be in, whether that be the negative space in between the chest wall and the lungs, or we may not have the ability for our patient to maintain any amount of pressure in their lungs because the lung is punctured. So there's an imbalance of pressure, and that imbalance, if left unchecked and left unchallenged, if we don't fix it, it can cause the lung itself to collapse. It won't be able to normally function. So one of the biggest things that we hear about, especially as we're going through EMT and really every aspect of first responder work out in the field in a medical sense, is the sucking chest wound. This is the wound that as soon as the patient has some type of foreign object inside of their chest, they are breathing and you can hear air entering and escaping from that cavity. That chest cavity is in fact open to the outside air, to the outside atmosphere. It may not be a sucking sound, but it is definitely a site for pretty significant infection as well as damage to the things that really keep our patient alive. And this goes right back to looking for the ABCs, airway, breathing, and circulation. This can pretty effectively cause issues with breathing, obviously, and it can also cause issues with circulation because the breathing is not actually circulating, allowing for enough circulation of oxygenated blood because we have a reduction in the amount of oxygen that's actually being brought in, as well as a reduction in the amount of carbon dioxide and other gases that are being expelled as waste. So your patient may not necessarily be showing the signs and symptoms right away, and that's our body's way of compensating. But a sucking chest wound can't necessarily be called a sucking chest wound based off of what we can see or hear. My best recommendation to providers everywhere is that any wound to the torso, as well as to the abdomen, any wound that is a puncture or penetrating wound to the torso, the abdomen, anything in our central area should be considered as trauma until we can absolutely rule out that it is not. So we need to make very sure that we are not underplaying the severity of that injury. Your patient care will mostly follow with the other patient care modalities that we've talked about in the past. We're going to maintain an open airway, seal the wound, and we'll seal the wound using not just our bandaging and our dressings as before. We're going to apply what's known as an occlusive dressing. We'll administer high concentrated O2 for any patients that need it, and for the most part, with these sucking chest wounds, your patient probably will need it, so we don't need to play the game of do they or don't they. This is a pretty appropriate time to give them oxygen. We're going to try to take care for any signs or symptoms of shock. We'll initiate immediate transport, and we should definitely consider ALS. If you're in an area where ALS is not readily available, we may want to consider an ALS intercept or perhaps air transportation. And if you're in an area where ALS is prevalent and is very available, we may want to stay on scene so that we can get ALS on board before we start transporting. In our metro areas, in our more crowded suburban and metro areas, ALS intercept doesn't exactly work. It's usually better to wait on scene for the extra 2 to 3 minutes for them to arrive than it would be to simply transport on your own to the hospital. But of course, follow your local protocols. You don't want to fall outside of what those local protocols state. So let's talk about these occlusive dressings, and we're going to talk about both occlusive and flutter valve dressings. An occlusive dressing is any dressing that's taped in place that is leaving a side or a corner of the dressing unsealed. When your patient inhales, the dressing will seal the wound. It will actually be sucked in and will seal the wound. And then as they exhale, that free corner will allow for air that's trapped in the chest cavity to be expelled. Now, these occlusive dressings are all over the place. They have many different variations. The one that we see most often, especially in the EMT classroom as well as on BLS ambulances, are known as petroleum gauze. But there are other designs that are fantastic. And, you know, again, to make sure that we're not breaking any copyright stuff, I'll go ahead and I'll link those up so you can take a look at those down below. As you can see in this diagram, this is an occlusive dressing, and it looks like this is a pretty simple homemade occlusive dressing. We have a bandage that is being adhered with tape, and the dressing itself looks to be a plastic material. Do note that even though this may be appropriate, if we have the right equipment on the ambulance, we probably shouldn't be stripping out our sandwich baggie and taping that directly to the patient's bare chest. So, of course, use the right tool for the right job. As the patient's breathing in, that plastic material is being sucked into the wound, and it's creating an impregnable seal that will not allow additional air to go into the space in between the lungs and the chest wall. And remember, that space is normally empty. There's nothing in there. So when we have things that get in there, additionally, air or blood, it will cause there to be pressure, undue pressure, forced upon the lung and will not allow for the full expansion and contraction of that lung. On the way out, as the patient is exhaling, you'll see that the air is pushed out from there. And this is especially important to remember if you have a patient that has, in fact, incurred an injury not only to their chest wall, but also to their lung. If the lung has been punctured and we have air that's leaking into the chest wall, as well as a break in the chest wall, we have air that's coming from two different directions, from the lung itself and through the airway, as well as through this new, not healthy hole in our chest wall. So we have to allow for air to be pushed out from its new home, which it should not be in, and we want to prevent any other air from coming into that space. And we're going to talk about what those are called. They're very special terms and a very specific type of trauma. Now, before we get there, I want you to think about these 3 points. Does your patient's chest injury need to be treated during the primary assessment? And it's important to go back and look at the way that we do our primary and secondary assessments and how those differ from things like our scene size up and our response and our after call. Also, does your patient have an open chest injury that requires an occlusive dressing? As I've stated before, anything that's on the chest or on the abdomen usually will require an occlusive dressing. If you have a patient with a significant injury to their abdominal quadrants, we actually have some specific care points for that. And we talk a little bit about it in chapter 26, and we'll talk about it further on when we get into other types of trauma. And finally, does the patient injury necessitate immediate transport to a trauma center? Now, this is always going to be based off of what your local protocols state, but here where we are, a patient with any type of a penetrating wound to the chest or abdomen is absolutely going to be going to a trauma center. And EMTs, remember, if the patient's trauma, they are going to immediately be ALS. So start hailing for ALS assistance on that if they're not already on their way. All right, we're finally at the point where we're going to start talking about those big fancy injuries that you hear about. We're going to talk about the following: pneumothoraxes, hemothoraxes, hemopneumothoraxes, traumatic asphyxia, cardiac tamponade, and aortic injuries and dissection. And it'll be a little bit different than the information that you've already received in my class, but if you're not in my class, we'll be talking specifically about aortic injury outside of and including the abdominal aortic aneurysm, or AAA. So let's start with pneumothoraxes and tension pneumothoraxes. These two terms are very often confusing and they are used interchangeably, so it's important that you note what the difference is between the two. So let's break these down. A pneumothorax is any time that air is entering the chest cavity. So anytime that we have air that's entering the chest cavity and has nowhere else to go. This would be in a case where we have a patient that has suffered a penetrating injury to the chest wall, but it has not necessarily affected the lung, or the affected aspect of the lung has not significantly attributed to anything else. Now, a tension pneumothorax is any time that we have a pneumothorax where air that's entering the chest cavity is prevented from escaping. Okay, so we'll have air that's built up and that is not going to allow the patient to effectively breathe because it will cause the lung to, again, not effectively fill and empty or contract and expand. Here's a picture of a patient that has suffered a pneumothorax. So we have the foreign object that has entered through the chest wall and is now putting pressure on that lung. If you look at the lung on the right, you can see that it's allowed to fill entirely or nearly to the borders of its space. So it's almost pushing to the point where it's hitting the chest wall. There is a little bit of room there, and that negative space is important to maintain so that we are allowed to take even larger breaths than normal under extreme circumstances, whether it be induced exercise or, as we all know, evolution has created our bodies to the point where we are now. If we're in a dead sprint running away from a dinosaur. I know some of you are about to hammer me on the comments with all this stuff. I'm just making a joke. I don't care to make any real statements about dinosaurs or any of that stuff. So let's move forward. The pneumothorax and tension pneumothorax are going to have pretty easily detectable signs, and it's important that you note these. the lung sounds are going to be diminished or absent, I should say, on the affected side. So at this point, it's important that we do take lung sounds. And if you haven't learned how to take lung sounds yet, it's an important skill to master while you are young in your career, because the further you go on without that ability, sometimes it can be a bit of an afterthought, something that we don't necessarily obtain on every patient. As you progress in your career, you'll find that lung sounds are extremely important to obtain, especially when we're dealing with a patient that has any kind of an issue, whether it be airway or breathing, because it can tell us what's going on. Now, on the other side of things, we have a hemothorax and hemopneumothoraxes. A hemothorax is when that chest cavity that is in between, that space in between the chest wall and the lungs, fills with blood instead of air. And a hemopneumothorax is when we have a chest cavity that fills with both blood and air. Now, I don't think that I really need to spend too much time explaining why these would be bad things, but remember, any type of issue where we have a foreign object entering the patient's chest cavity, you could have a potential hemopneumothorax, you could have a regular pneumothorax, any type of issue with the thoracic cavity, and that's where we get the root or the suffix of thorax, is going to negatively affect your patient's ability to breathe effectively. So have that bag valve mask out. Prepare to put your patient on high flow O2, even if it doesn't look like they need it right now. Be ready for it when they do, because if they have one of these injuries, they will. So you can see here in the diagram, we've got air that's entering that negative cavity outside of the lung on the left, and it's being pushed up against that chest wall. That's our pneumothorax. On the other side, in the middle, we have blood that's filling that negative space, and we have a hemothorax. And then, all the way to the right, we have half blood, half air, and it doesn't need to be half or half of anything. If we have blood and air in that space in between the chest wall and the lung, we have a hemopneumothorax. As providers, it's not necessarily going to be a major thing to determine. If we've determined that they have a pneumothorax, and then when we get into the hospital we find out that they had a hemopneumo, typically as EMTs, and this is a pretty across the board statement, as EMTs we don't have many tools that we can do to effectively treat that. That tends to fall into our ALS side with paramedics and other field providers at a higher level, as well as at the hospital. When we're dealing with these injuries, it's also important to remember that because we are working to fix an issue with the primary components of regular respiration, or that exchange of gases at the alveolar level, that they may not eventually be productive enough for our patient to breathe at all. This will lead to a phenomenon known as traumatic asphyxia, and it may not necessarily be due to compression. It could also be due to an unresolved pneumothorax or hemothorax or hemopneumothorax or even a tension pneumothorax. Remember that traumatic asphyxia is just like drowning without the convenience of being in a pool. This is something that has to do with our body's ability to effectively ventilate itself. Traumatic asphyxia will lead to, eventually, if it's left unfixed, to a phenomenon known as respiratory arrest. So let's talk about traumatic asphyxia. It's a sudden compression of the chest that forces blood out of the organs and ruptures blood vessels. The neck and face may be darker in color than the rest of the body, and it may cause bulging eyes, distended neck veins, and broken blood vessels in the face. However, those aren't going to be solid determining factors. If your patient has had some type of compression injury to the chest and they are having difficulty breathing, we want to make sure that we are treating them as if they had a traumatic event that could cause asphyxia. Cardiac tamponade is in a very different ballpark from all the rest of the injuries that we're talking about, but because it does reside in the thorax, inside of the chest cavity, we want to talk about it. Cardiac tamponade is a direct injury to the heart that causes blood to flow into the pericardial sac that surrounds the heart, and it increases pressure on the heart so that the chambers can't fill. Much in the same way that we have that blood or air putting pressure on the lungs and not allowing them to expand and contract normally. It's the same phenomenon here. However, the damage is occurring in the heart. Cardiac tamponade, if we leave it untreated, will kill our patient very, very quickly. And it's not necessarily going to be less than 2 minutes transport, they're just dead anyway, so why even bother transporting kind of thing. Cardiac tamponade can be a very slow onset, but it is something that we want to be on the lookout for. Now, with cardiac tamponade, it does have its own signs and symptoms that we'll talk about in a little bit, and you should definitely go to your textbook to see what they recommend to look for, but you can look for some pretty obvious signs and symptoms. Your patient has an increasing blood pressure that suddenly tanks, it falls. They have a cardiac rate, or they have a pulse rate that goes up and then starts to slowly fall or rapidly fall. And the patient looks hypoxic all over. They have system-wide lack of oxygen, and again, we call that hypoxia. So this patient is in a place of hypoxia because the heart isn't able to effectively pump out the blood the way that it normally would, which is going to affect every part of the body. So it's super important to look for those signs because those will be universal. Okay? With cardiac tamponade, this blood that's backing up into the veins, may cause a very obvious sign, and that would be distended neck veins. Now, I'm going to go ahead and I'm going to bring this up because I think it's important. When my dad used to get angry, well, my dad still gets angry. He still gets angry. But when he used to get angry at me as a kid, I knew it because I could see that all those veins in his head, his forehead, and his neck, they would start popping out, and I was thinking, oh man, I really did it this time. My dad's so angry, his head's gonna pop off. That's not necessarily going to lead me to believe that my dad had cardiac tamponade all those times that I got in trouble at school, or maybe put an accidental hole in the wall because I was practicing karate in my bedroom. But I will say this: if your patient has a distended jugular vein, or has JVD, jugular vein distension, as we refer to it in my class, that's a pretty good indicator that the patient is dealing with cardiac tamponade. It's very obvious. It is a vein that runs on either side of the trachea, and it shouldn't have a pulse. If it has a pulse, that's the carotid artery. You're in the wrong place. If it's distended and has no pulsating affect to it, that's jugular vein distension. Your patient's probably dealing with cardiac tamponade, or just one of the worst strokes of their life. And if it is a stroke, you'll be able to tell by those neurological deficits. They'll have some type of paralysis or hemiparesis, where they've got paralysis on one side, drooping face, aphasia, dysphagia, any of the number of things we've talked about in my class previously. Also, remember that shock is going to be very quickly onset in the case of cardiac tamponade if it's left untreated, because the patient will not be effectively oxygenating the rest of the tissue of the body. Narrowed pulse pressure is a little bit difficult, especially at the EMT level, but it is something that we should bring up. And this would be the difference between the systolic and the diastolic blood pressure getting more and more narrow, but I would not anticipate that that would be something we could effectively document if we were dealing with a very short transport time. However, on longer transport times, or with patients that stay on scene longer, it may be something that we can document. Aortic injury will deal with the largest blood vessel in the body, as opposed to just the heart. We've talked about AAAs in my class before, or the abdominal aortic aneurysm, and my students will already know that injuries to the aorta are significant. They are time sensitive, and this is probably the one patient that you can't afford to drive as fast as you can with, because that may in fact cause the bleeding to become worse. A patient that has an abdominal aortic aneurysm or has any type of injury to the aorta may bleed so significantly that there's no way that we can possibly stop that bleeding. We call that exsanguination or fatal hemorrhage. These types of injuries to the aorta can be from penetrating trauma, blunt trauma. They can be from blast injuries, and it could just be from high pressure bleeding or from high blood pressure in and of itself. The fact that these are injuries that span everything from trauma to medical should, in your mind, tell you that they are not happening on a daily basis. In my own experience, I've never had a true AAA. I've never had a true aortic injury that I've been able to record, but it does lend itself to the concept that early identification will always help our patient when it comes to treatment. These patients will have pretty similar complaints. Pain in their chest, their abdomen, their back, and it will be referred pain that originates somewhere in the abdomen and goes directly to the back, alongside signs of shock. Now, patients that are complaining of these things with no obvious signs of trauma or with no obvious complaint of trauma, there's no mechanism there, especially in patients that are showing signs of shock or have poor vital signs, that can be a major determining factor on where they're going, because you really don't want to take your patient that's having a AAA or has any type of aortic injury to go to a regular hospital. They're simply not staffed or equipped to deal with that. I don't know if you guys can hear it, but the fire station that's right down the street from my place is heading out the door, and who knows? Maybe they're going to a AAA. You never know. Now, back to what we were talking about here. One key difference that you should look for would be differences in pulse or blood pressure between the right and left arms, or pulses that are different between the arms and the legs, or between the arms and the legs themselves. These will be pretty difficult to do unless we have multiple cuffs, because the time that it takes for us to swap the cuffs, in all honesty, isn't that long. But the time to go over to the other side of your patient, especially on a trauma patient, may be less important if we are seeing the other signs. They've got the complaint of chest pain, back pain, abdominal pain, with the signs of shock. At that point, I wouldn't really focus too much on trying to get a blood pressure on the right or left arm, and then on the right and left thigh. I would more likely focus on the fact that they were becoming hypoxic or were showing the signs of shock. Finally, we have the very uncommon call that we receive typically at sporting events, especially baseball and hockey. This is called commotio cordis, and commotio cordis is a very rare call, but it does happen enough to the point where it is almost mandatory throughout all of the United States that sporting venues, whether they be professional, amateur, or even at the scholastic level, K through 12, or at the college level, that they have an AED. The reason why is because these individuals are dealing with high velocity objects. A high velocity object, especially when we're dealing with velocities that are well over 70, 80, 90, even 100 miles an hour, when they come in contact with the chest, especially when they come in contact with the chest that's very close to the heart, they can cause there to be a brief but fatal disruption in the electrical conductivity of the heart. It would be probably unwise to go into the electrical phenomenon that goes along with commotio cordis, but you should know that these patients will go from standing upright to being on the ground immediately, and they will be in cardiac arrest. If you have any patient where you're responding to someone that was struck in the chest and they collapse and they're pulseless, you can pretty easily assume that it's commotio cordis, and hopefully, and I say this because this would actually be better for our patient, we find that they're in ventricular fibrillation, or VF. By providing excellent high quality CPR as well as early defibrillation, that's going to be our patient's best chance for coming back. And the best part of our AEDs is that it will rapidly identify a state of ventricular fibrillation, or VFib, and it will advise for a shock as soon as it can possibly do so by charging up and being ready to go. So commotio cordis, we do see this a fair amount with sporting events. So try to think of that. If you got a patient that suddenly collapsed after being struck in the chest, you should be thinking commotio cordis. It's a traumatic injury, it's a blunt trauma injury, but really it's a cardiac arrest emergency that you're going to be dealing with. Moving away from the chest, now we're talking about abdominal injuries. And as we've already discussed in other chapters, especially when we talked about abdominal medical injuries, we already know that the majority of our solid and hollow organs reside in our abdominal cavity. So abdominal injuries are significant, they are difficult to treat and diagnose, and they are very difficult to recover from in the long term. So just wanted to put that out there real quick. If you have a patient with an abdominal injury, it may not be nearly as cool as that gunshot wound to the chest or the sucking chest wound or anything like that, but these are the patients that are going to require a lot of additional assistance to recover and walk out of the hospital. Abdominal injuries can be open or closed. Internal bleeding can be severe, it could be minor. There could be serious painful reactions if hollow organs rupture, and there can be serious painful reactions if solid organs are somehow caused to leak by pressure. And we may have one of our more significant injuries, an evisceration, occur where organs are protruding through the wound. I think that in popular media, we've seen eviscerations where an individual is cut with a sword or a knife, and their, as they like to say it, their guts were spilling out. We actually have a pretty good way of treating that, and we're going to talk about that in just a few slides. Okay, so this is obviously not a real injury. It looks like this individual fell off of a ladder and was able to either lacerate their abdominal quadrant with the shears that they're holding in their hand, or because of some type of a broken material that you see laying to the patient's left side under their left arm. But what's important to note is that it looks like there are abdominal quadrants that are protruding from that abdominal area. So they've got those organs that are protruding, and it looks like it's in the right lower quadrant. So we would anticipate that to be possibly part of the large or small intestine. Your patient assessment will probably reveal the following. The patient will be in pain. That pain may be mild and may be becoming rapidly more intolerable. They may be complaining of cramps, nausea, vomiting, weakness, thirst, and they will probably present with some obvious lacerations and puncture wounds to the abdomen, in addition to having any type of organs that are protruding from that space. Also, we should be very aware of lacerations and punctures to the pelvis, the middle and lower back. And we want to try to identify if we have a patient that's complaining of pain in the front, make sure that we assess the back. If they've got a hole in the front, they may again have a hole in the back. We also want to look for indications of blunt trauma, bruising, reddening of the skin, raised or deformed areas on the abdomen, indications of developing shock, whether that be deteriorating vital signs, deteriorating mental status, or deteriorating skin signs. Any patient that's coughing or vomiting up blood, any patient that presents with a rigid or tender abdomen, any type of distension of the abdomen. And no, I'm not talking about someone that's just fat. I'm talking about someone that has an obvious distension of the abdomen. And of course, the all too familiar patient that's just trying their best not to move. And I want you to think back to the last time you had a really, really bad stomach ache. The thing that probably made you feel better wasn't going for a 10-mile run. It was laying in a very specific position. It may have been the fetal position. It may have been laying on your side. It may have been laying on your back. Every single person out there, I don't care who you are, has had abdominal pain at some point. And when it's severe enough or significant enough, a lot of times the most that we can do is try to limit our movement as much as possible. So if your patient's clearly trying to do that, go ahead and make a note of that. It actually is significant. All right. Also, stay alert for vomiting and keep their airway open. Make sure that we are able to place the patient on their back with their legs flexed, or if it makes more sense for them, we can place them left lateral if it has to do with comfort. And we also want to consider high flow O2 and care for shock, as well as not giving them anything by mouth, monitoring their vital signs every 5 minutes, and initiating transport as soon as possible. We also want to make sure that we control external bleeding and triage all the wounds. Now, this is a big one. You'll often hear that individuals are having their organs stuffed back into their areas where they came from. We really want to try to avoid touching any of the eviscerated organs. We'll actually treat these a little bit differently than other injuries because we want to try to keep them as moist as possible. So apply a sterile dressing that has been moistened with a sterile saline over the wound site and continue to assess if that is drying out, especially if it's a long transport. But don't try to force all of those in. We're just going to leave them where they are and then keep them in position outside of the body. Okay? We also want to make sure that we maintain warmth of the patient by use of blankets and heaters in the back of our ambulances, as well as use of bulky dressings over occlusive dressings. And we also want to make sure that we don't remove any impaled objects. Again, the only time that we're going to remove an impaled object is if it interferes with the airway or with chest compressions. So removing these objects from the abdomen would not be acceptable. However, if we've determined that the object is so large that we can't fit our patient in the back of the ambulance, we'll go ahead and reach out to our fire department personnel or local rescue personnel so that we can go ahead and cut that down with specialized tools so that we can transport. Also, we want to make sure that we stabilize these bulky dressings in place. It's not worthwhile if they're just laying there, especially because we're going to need to move the patient at some point. So do your very best to use tape to get those in place. I do realize that that can be a hard thing to do, and sometimes it can be impossible. So if that's not possible to tape them down, let's go ahead and try to position them in a way that when we move them, that those bandages don't fall off. Also, we want to make sure that our patient's legs are left in a position that is near the way that we found them, so that we don't move any impaled objects more than they already have been. But it's also important to remember that getting the patient into the ambulance is going to be the next step into getting them better care. So if we have to move their legs a little bit or have to make adjustments to that object to get them to the hospital, then that's what we need to do. Now, we've gone through chest and abdominal injuries. I know that it feels a little fast, so we're going to do a quick review. We're going to talk about some points to consider, and then we're going to finish up with our patient of the day. Here we go. Alrighty, here we go. An open chest or abdominal wound is considered to be one that penetrates not only the skin, but the chest and abdominal wall to expose internal organs. Open chest and abdominal wounds are life-threatening. For any open chest or abdominal wound, we should try to apply an occlusive dressing. However, an occlusive dressing may not be appropriate if it doesn't fit or if we have organs that are protruding. For both open and closed injuries, take appropriate standard precautions. Note the mechanism of injury, protect the patient's airway and breathing, administer high concentrated oxygen by non-rebreather mask, treat for shock, and transport. Also, remember that any open or closed trauma may in fact turn into a patient that is coughing or is vomiting blood. So standard precautions for these trauma calls may also include goggles, face masks, and gowns. A flail chest is characterized by paradoxical motion, or motion going in two opposite directions. If the patient is unable to adequately breathe, assist their ventilations carefully, but don't overventilate because we can cause additional trauma. We should seal any open chest wound with an occlusive dressing that's taped on 3 sides or in some other manner so that it acts as a one-way valve that allows air in and out of the chest, but not in. Alternatively, use a commercial device such as the Asherman chest seal or ACS with a one-way valve to relieve pressure. Now, we're in a process of transition right now, and it looks as if the American College of Trauma Surgeons is planning on issuing some new guidance on this. So as of today, April 9th, 2020, it is considered most appropriate to use a 3-sided chest seal to act as an occlusive dressing on any type of chest wound that is penetrating. That's per the national standard. Our standards here where I teach are a little bit different. My students are probably already aware of that, so they're already pulling their hair out at home as they listen to this PowerPoint. But for those of you that aren't in my class, remember that the national standard is 3-sided, 3. We should also make sure that we monitor the patient for changes and prepare to manually relieve any pressure in the chest. Manual relief of pressure in the chest is from pulling up a tab of that chest seal, of that occlusive dressing, to allow for more air to escape. And it may be indicated by a patient who is stating that they have more pain on that side. They're developing some type of tracheal deviation, or it is evident that the chest seal is being pretty significantly pulled into that wound. Remember, closed chest wounds are sometimes difficult to distinguish and may occur differently in every patient, and they may occur together. So assess your patient, including breath sounds, maintain ventilation, oxygenation, and perfusion. Patients who collapse in cardiac arrest after a force to the center of the chest or to the left side of the chest should receive CPR and defibrillation like any other arrest from cardiac arrest, from a cardiac cause or from traumatic arrest. This is most commonly referred to as commotio cordis. If a patient develops signs of tension pneumothorax, we should arrange for immediate ALS intercept, or we should commit to transport to a trauma center that can treat this type of injury. When solid abdominal organs are injured, life-threatening amounts of blood loss can occur. When hollow abdominal organs are injured, their contents may spill into the abdominal cavity and may cause irritation and sepsis. Remember that blunt trauma, penetrating trauma, and compression are mechanisms that can injure the chest and abdomen. Open or closed pertains to the integrity of the chest and abdominal wall after injury, not necessarily the layers of the skin. We should seal open chest wounds to prevent air from entering the chest cavity. And we should also note that closed chest and abdominal wounds bear a high risk for underlying organ system damage and internal bleeding. Use the mechanism of injury and patient assessment to recognize the signs and symptoms of shock. And always treat the patient, not the injuries. If your patient is starting to become hypoxic, apply oxygen and prepare to utilize positive pressure ventilation by bag valve mask. If the patient is stating that they are in pain in a certain position and it's appropriate, we may actually want to move them to a different position if it does relieve some pain, and so on and so forth. EMTs need to learn the signs and symptoms of chest and abdominal injuries, as well as treatment procedures for specific chest and abdominal injuries, which we've talked about and we'll do more skills on. Some questions to consider for abdominal and chest wall injuries. Is the patient's breathing adequate, inadequate, or absent? Is the patient displaying signs of shock? Is there an open wound in the chest that needs to be sealed? Is the patient displaying signs of a tension pneumothorax? Is there any open wound in the abdomen that needs to be dressed and covered? All right, here we go. Critical thinking time. You are caring for a patient who was shot in the chest with a nail gun. You've applied an occlusive dressing around the wound when all of a sudden your patient begins to deteriorate. They're having extreme difficulty breathing and their color has worsened. Breath sounds have become almost totally absent on the side with the impaled nail. What complication might you suspect is causing his worsening condition, and how can this be corrected? Go ahead and answer down below in the comments, and I'll go ahead and answer. And as always, please like, subscribe, and continue to watch for more education from the Band-Aid Man OC. Have a great one, everyone. We'll talk soon. Bye-bye.